you know, I got home a little early so I could go in and make sure it worked for me. So
Live now, and as people join us, then they will join us. So I want to welcome the group to the We Are Champions lecture series. This afternoon, TMC Cardiac Innovations, Paving the Road Ahead with Dr. Neil Gheewala. My name is Adeline Clemenson, and I am the chair of We Are Champions, and we are thrilled. We have heard so much about this doctor and his work that I'm just very excited to hear what he has to share with us today. I don't want to embarrass him, but I heard that he's like a young Dr. Sethi. So I'm looking forward to what he's going to tell us. I want to do a quick introduction of him. He is a structural interventional cardiologist, that's a mouthful, who specializes in coronary artery disease and heart valve disorders. He's from Florida. He's a Florida native, and he graduated from medical school as a member of Alpha Omega Alpha, which is a medical honor society, which recognizes physicians with exceptional academic ability, compassion in patient care, and dedication to furthering the field of medicine. At Harvard, Brown, and the renowned Henry Ford Hospital, he trained with pioneers in the field of cardiovascular medicine. He performs cutting-edge procedures at the forefront of interventional cardiology. He has a passion for taking care of patients with complex medical conditions whose requirements supersede traditional therapies. His personal interests include football, American history, traveling, and golf. So golf seems to be a popular venue for a lot of our members. So without further ado, I want to give him plenty of time to go over his presentation with us and leave time for question and answers at the end. So if you, would you prefer that we allow you to give your presentation and then answer questions, or can people raise their hand or ask questions in the chat box?
Oh.
We can't hear you.
Now.
Oh, there you go.
Okay. What I was saying is that feel free to go ahead and just raise hands and ask questions during the talk. I'm totally fine with that.
Okay, great. So go ahead and start with us.
All right. Well, Adeline, thank you so much, and Donald and Julie and Megan, thank you so much for all the hard work you put into put on this program.
Sorry, Dr. Gheewala, can you talk a little louder? You sound like you're far, far away.
I am not that far away. I can talk louder.
I know.
You might want to turn up your volume a little bit.
I think that might be it.
Where do I do that?
It's just a little microphone on your computer. I don't know what kind of computer you have, but it
is an Apple.
Oh, so the far right, just increase the volume. Top far right.
Hear me now much better now.
Same.
Yeah, a little bit better, but.
Gosh.
If everyone turns their own sound up to full bar, it'll work. Because I can hear you when I turn mine up.
Okay, so you can hear me. Okay, good. Okay. All right. Well, sorry about the audio difficulties, but thank you guys so much for having me. It's quite a pleasure to be here and to be able to present. I've been in Tucson for about 4 years now, and and I'm with Pima Heart and Vascular, and I've had such a great experience at TMC, and we've been able to take our program to the next level, not only clinically, but also bring in new innovations that I think are really helping to pave the road ahead for patients. And I'd like to introduce that to everyone tonight. I want you to feel free to ask questions. If things don't make sense, ask me questions. If there's some other questions you might have that are relevant, please stop me. I think this is more fun when it's interactive. So I think without further ado, what we can do is we can go ahead and have the slides up.
Just 1 second.
Okay, great. All right, so the title of my talk tonight is TMC Cardiac Innovations and how we're paving the road ahead. I'm the Assistant Director of the Structural Heart Program, the Associate Fellowship Program Director for our inaugural fellow that is starting in July, and we're having a visiting fellow visiting from Brown University starting next week to come and learn some of our techniques. We can go to the next slide. So I think it's always nice to start with, what are we doing? So, so a little bit of background. So I'm a cardiologist, but I specialize in structural heart. And what does that mean? So most cardiologists spend their time, there's a lot of cardiologists that are general cardiologists that spend a lot of time diagnosing things. And then there are interventional cardiologists that specialize in coronary artery disease, that specialize in putting in stents and doing other heart measurements and pressures. And then a structural heart cardiologist deals with not only heart arteries, but we deal with valves, we deal with appendages and other structures in the heart that have long been ignored, that we have traditionally left to the surgeons to help us address those issues in our patients. So when we use the term percutaneous means that we're doing it in a non-surgical way. So when we talk about stents, we use the term percutaneous coronary intervention. All percutaneous means is that it doesn't involve a blade for us to cut people open. And for the last 50 years, open heart issues have been addressed with, valve issues and other issues with the heart have been dealt with by open heart surgery. So different types of open heart surgeries. There's minimally invasive, there's robotic, there's bypass surgery, there's just valve replacements, and then there's also closures of hole in the hearts. Now, since the late 1970s, we have had advancements in what's called percutaneous techniques. So for a long time, people have, even before the 70s, have had, cardiac catheterization angiograms have been around since the early 1960s. And people, we would go up from the groin up to the heart, snake a tube up there, inject X-ray dye and contrast into these heart arteries, and be able to understand that when people have chest pain, that they have blockages, and those blockages need to be addressed. But there was a lot of research that was going on in the early 1970s, and the thought leaders were thinking very early on, this is almost 50 years ago, that some of these issues that we were dealing with open heart surgery could be dealt with in what we call percutaneous fashion, meaning trying to use a wire, a balloon, and a stent, which is kind of the concept that we use. So the concept here is that if we can put a wire through the vessel, essentially if you can get a camera down your drain and you're able to, get a rotor-rooter down the drain, right? If you can get something down there to scope it down there, then you can deliver whatever other device that's needed. In this case, the heart is only a pump. It's in its simplest fashion. It's really a plumbing problem that I am solving. And so if we can find a way to get there and get a guide wire there to be able to get there, then we can use that as a rail to deliver things. And that's the concept in all of interventional cardiology and structural cardiology that we do, which is using a guide wire and a rail to get to where we need to go. However, it's not that simple because technology had to catch up with our with the ideas that people had. The technology 50 years ago certainly was much less deliverable than it is today. They were oftentimes much bulkier, and there were things that there were considerations that we didn't even have at the time. We can go to the next slide. So, as I mentioned, balloon angioplasty was the first revolution in interventional cardiology, and that was in the late 1970s. There's a guy named Andreas Grunsig, and he was a cardiologist at Emory, and unfortunately died in a plane crash back in 1986. But he is the father of percutaneous coronary interventions, and he opened up the gateway to all the fascinating things we're able to do to fix mitral valves with MitraClip, fixing aortic valves with TAVR, putting in Watchmans for people who have AFib that can't be on blood thinners. But essentially, he was the one who pioneered that if I can get a wire there, then I can get something there. and in his case, it was a balloon. That was the device. That's all he had. So as you can see down below, you can access vessels from the groin or from the arm, snake tubes up to the heart. And then if you can get a wire through it, you can see that on the, what is the coronary angioplasty cartoon there. You can say if you get a wire through it, you can get a balloon there, blow up that balloon, and then modify that plaque so that way blood is free to flow. Now, initially, we weren't very good at it. there were, you think that there were a lot of considerations that we didn't know to ask. But 50 years later, we have a very high success rate in doing angioplasties and putting in stents. Next slide, please. So one of my favorite quotes here from Don Rumsfeld is, there are known knowns, which are the things that we do know. There are known unknowns. There are things that, to say basically that we know that there are some things that we don't know. And there are unknowns, questions that, things that we don't even know to ask that question. And I think that when I think about technological innovations and paving the way forward for that, Rumsfeld's quote is something that we really have to, that helps guide me as far as where we need to go and what considerations we have, especially at TMC with a very large and robust research program and doing things that are ahead of other people. Sometimes we don't get the results that we necessarily anticipate, not necessarily because of necessarily a technical error, but there may be considerations that we may not have even known to even ask about in the past. And so with doing more and more of these procedures in a regulated and a safe fashion and being thoughtful about learning from every patient experience, we're able to get to the point where there are known knowns. And that's how everything that we have today that is FDA and commercially available to us has come to fruition. Go to the next slides. So using the Rumsfeld concept here, step one innovation is to transition from an unknown to a known unknown. So basically to find something that somebody else can discover. And so as I mentioned, we learned that angioplasty didn't work in some people very well. And in some people worked very well. And so and the things that we learned through doing angioplasty, again, 50 years ago, is in the patients where it worked very well, we knew that the vessel wasn't all that calcified. We knew that it was a kind of a straighter vessel. And so what we found is that in a calcified vessel that was very tortuous, meaning very bendy, these were considerations from the patient's anatomy where we could say that, gosh, we've learned that maybe in these particular instances, these people would do better with bypass surgery than doing angioplasty. Now, the equipment that we had back then, as I mentioned, was quite bulky and it was quite not very deliverable at all. So sort of put these into two factors. One is where you blame the patient, and the other one where you blame the doctor. And I think that as we sort of put these different factors in and say, okay, well, things didn't go according to plan, and always take that time to say, well, why was that not the case? That's how we learn something. And then for our next patient, we're able to make sure that innovation moves forward in a more expeditious fashion. Next slide, please. So step two in innovation is to transition from known unknowns to known knowns. So things that we all know. So once we, losing the angioplasty example again, once we learn that, gosh, maybe if it's calcified, tortuous, maybe we should just leave those things alone, we found that the angioplasty outcomes got much better and the patients did much better and survived an angioplasty and didn't have a major complication. Now, knowing that there were technical limitations and that there were certain patients that just were not great candidates for bypass surgery, we knew that the future of coronary interventions with angioplasty was in its infancy. And so there was a stent that was created. So somebody thought that, gosh, if we put a metal scaffold here and we were able to blow this up in a calcified vessel that can oftentimes recoil, if we put a metal scaffold there, somebody had the idea that that would work. And so Palma Schatz, there were two physicians that created the coronary stent. They live somewhere in Malibu now, and they created the stent that was introduced by Johnson & Johnson. As you can see, there's a very primitive chain-linked stent that was crimped on a balloon. Every stent was cut to size what they needed and crimped on a balloon manually. And as you can see here, it looks quite prominent. And for a very straight vessel, this would work very well. But one that was very bendy and tortuous, the stent would not work nearly as well. But it was in the right direction because it was addressing some of the things that we had learned early on from our angioplasty experience almost 40, 50 years ago now. Next slide, please. Now, the next step is to advance what we know even further, advancing our known knowns, learning from our known unknowns, and to look out for even more unknown unknowns, because once you start to conquer one thing that you've learned, then you find out that there may be other things that we never even thought to ask about because we didn't get to the point where we could even ask that question. And so it's sort of like, the first generation of stents. It's kind of like the iPhone back in 2007. Everybody was excited about it. But if I had to say, hey, let's exchange your iPhone 12 for from a 2007 original throwback iPhone, I don't think that there's a single person on this call or person that I've yet to meet that would actually want to go backwards and do that stuff. But as you can see, that at the time in 2007, the original iPhone, it was fantastic. It was great. It was certainly a step up from the BlackBerry. But now with an iPhone 12, there's no way that we would ever go back to the way we had. But it's because we kept paving the way forward with technological innovation. So what it's done in the tech industry, of course, it's on a different magnitude. It's impacting different people's lives, the iPhone, in a much different way, in a very different way that stents are. But the concept of the evolution that we've come to say that, gosh, here's how we can actually make a difference and believe in the procedures that we have, although there may be some outcomes we wish could be different, to pave the full way forward and say, gosh, there are things that we can learn from this and new technological innovations that can do this. So now we're on the 4th generation stents that are extremely deliverable. Nationally, there's a 98% success rate in stenting, in putting in stents during a heart attack, which is revolutionary because now heart attack patients go home in 2 days, whereas 25 years ago, those patients were oftentimes in the hospital for a week, and we would put them in the ICU. We would make sure they're on the right drips. We would make sure their blood pressure was monitored to a dime. And we still do a lot of those things, but those patients don't go to the ICU anymore. Those patients, come into the hospital on death's door, and within 60 to 90 minutes, oftentimes are recovering and able to breathe better and not have any chest pain and suffering, and their families know almost immediately that they're doing much better. So that 98% success rate is a testament to the 50 years of technological innovation that we've had to believe that, gosh, angioplasty was something that conceptually was a great idea, but just needed a lot of work. But the technology followed the path forward with new knowns that we had in the field. And just to mention, TMC is one of the largest open heart surgery programs and one of the largest cath labs in the state. And we do the highest number of open hearts in the state of Arizona. So next slide, please. So what's the next technological revolution within cardiology? So structural heart disease is what I do. And I truly believe that we're in the infancy of this. Last year, Dr. Sethi and I, we did a program together, the TMC Cardiac Symposium, and he hosted it. He was kind enough to ask me to speak, and I spoke about the future of mitral valve disease. And he mentioned to me, he mentions at the end of the quip that he's like, it's good, but surgery still is a complete solution. And I challenge that in 10 years from now, we should re-debate this again, because the technology is catching up to the limitations that we know that the current technology has. So as I mentioned, as you can see here on the lower diagram, where you see the coronary arteries here in red on top of the heart, that is what we've spent the last 50 years trying to address, either with open heart surgery or with angioplasty and stents. But the cartoon diagram to the next of it, where you can see the valves in white, you can see the walls between the chambers of the heart and other chambers in the heart as well. The rest, what I said, the rest of the heart, that's what the next 50 years is going to be a revolution in that technology. And I think that's going to be the bulk of my career, is understanding how we can best address all 4 of these valves without the need of open heart surgery, and then to decide which technology is going to be better for this individual patient. Because as you can see here on the cartoon there, we have 4 valves in the heart, but they're all shaped differently. We have the second most important valve in the heart is called the mitral valve, as you can see on the lower left-hand side. And that valve is very, very anatomically different than the most important valve in the heart, which is called the aortic valve, which sits right above it. And that's the valve that lets blood flow out of the heart. But those valves are addressed in 2 very different ways. And as aortic valve disease is kind of like vanilla, you know, it's kind of narrow, it's kind of a circle, you put a circle in and you fix it. The mitral valve geometry is very different. And as we've learned, as we've used certain technologies to repair the valve, only now have we been able to say, gosh, well, the technology we have is limitation, but maybe if we modify the technology or use a different concept in the technology to stratify patients with not all mitral valve disease is vanilla, it could be pistachio, or it could be chocolate, or it could be rocky road. That's something that that in the next decade we're going to be doing and doing a much better job of. We can go to the next slide, please. So as I take a step back from what I was just talking about, what is structural heart disease? You know, it's a very broad spectrum of things, and as you can see here on this very busy slide, we're dealing with non-coronary issues, but you know, as you can see here in one part, we have valves that are crimped on a stent. So it's just like what Dr. Grun said. He said, well, if we can put a wire somewhere, then we can deliver something. Well, that's the same concept with valves that are mounted on stents. The TAVR valves, those are things that we can do. Now we can close holes in the heart without the need of open heart surgery. As you can see, the closure devices here on the top left side of the screen. And there's multiple other things that we're going to talk about here briefly that we can address. Next slide. So TAVR, so transcatheter aortic valve replacement, and that is the first technology after coronary angioplasty that has revolutionized interventional cardiology and actually created the birth of the field of structural heart disease. As you can see below, as you can see in the diagram here, is that we have, this is a model of the valve, and this is a valve that is, again, blown up over a balloon. So it's the same concept Dr. Grunsing had in angioplasty. You have a blockage, you have a narrowing, you have a balloon, and then you have something over it. And in coronaries, we call them stents. Well, these are stented valves. So these are crimped on the balloon, and then we blow up the balloon and we're able to put it right in the place that we want to do it. And so at TMC, we've done over 700 such procedures. Last year, we did the largest number of TAVRs in the state, approximately 230 of these. And in general, we can do these from the groin, but we have very different ways to help patients with different anatomic challenges, because for not every patient is necessarily a surgical candidate. And those who are not surgical candidates, and we cannot go through the groin, at TMC, we now have multiple ways to be able to put in valves through other ways. You know, instead of going through the groin through an artery, sometimes we can go through a vein. Sometimes we can put it through the neck. Sometimes we can go through the shoulder. And so there's, you know, our goal here is to have individualized care based upon who the patient is right in front of us. And I think that in particular, what is interesting about TAVR is that we were one of the first to have 3 different valves choices on the market about 2 years that were available 2 years ago on the market, which again helped us individualize therapy from a commercially approved FDA basis. So, next slide, please. So the next most important valve is the mitral valve. So as you can see on the cartoon, a normal mitral valve usually comes together, but when it's leaking, there's a gap between those leaflets. And there's a lot of different reasons for the gap to form. Sometimes the valve can be an innocent bystander and the valve is just being pulled apart because of a ventricle problem. Sometimes the valve is the culprit itself, and the valve just is just not coming together because it's very calcified, or it broke from those little chordae. You can see the little strings that the valve are attached to. Sometimes those can come apart. So identifying exactly what the cause of the leakiness is helps us tailor the therapy. Right now, there's only one FDA-approved device that is available to patients, and that's called the mitral valve clip. And essentially what it does is it bridges that gap between the two leaflets together using a clip. So you can see on the bottom diagram that an example of a catheter coming down above the valve and grabbing those 2 leaflets to bring them together. So that way that gap that you can see on the upper left-hand side looks closer to normal than it does when it's leaking. And that's essentially what we're doing, is finding the index pathology, bring it together, so that way these leaflets can come together and give patients relief from mitral regurgitation. Now, what I'm really proud of is that we did almost 120 of these last year, and we were second in the entire country for the number of MitraClips that were performed. So we were right behind Cedars-Sinai, which goes to show that there's a large need here in Tucson with our population of patients who can be well served. And I think there's two reasons for this. One, I think that our referring community does a great job of identifying these patients. But second, we've had a lot of support from TMC to be able to have, the second hybrid lab, to have anesthesia support, to have cath lab staff. The hospital's done a lot to help us to do these procedures, efficiently. On a given Wednesday, we call them mitral Wednesdays. We can do anywhere from 2 to 6 of these procedures on a given day, and that is a testament to the amount of support that TMC and the priority that they made to advancing the TAVRs and MitraClip program. Next slide. Now, left atrial appendage occlusion, that's another very major procedure that we perform at TMC. We were top 15 in the country in terms of number of Watchmans implanted. This is a procedure that was approved in 2015, and what it involves is a plug in a certain part of the heart called the appendage. So it's kind of like an appendix. Most people, I'm sure most of you know that an appendix, there's really no biologic function other than to get infected and cause appendicitis, and some surgeon has to take it out. Well, this is no different. Your heart has an appendix. And evolutionary, we don't know exactly why that's the case, but what we know is that when people have an irregular heartbeat called atrial fibrillation, blood clots can form in the appendage, and that's where the blood clots live. And then they break off and they can cause a stroke, or they can go to the legs or go to the kidneys and cause all sorts of other problems. So the mainstay of therapy still is putting patients on blood thinners. And frankly, if you can take a tablet, why go undergo a procedure? But the tablet's great until you start having problems with the tablet, meaning people who are on blood thinners can bleed, which is obvious. People who get older are more likely to fall or trip and fall. So in those cases, it might be better to come off of blood thinners. And so that's why we have this procedure called Watchman, which is an incredibly safe procedure to put a plug up inside the heart. That's Watchman Thursdays. So that's our theme of the week. So TAVRs on Tuesdays, mitrals on Wednesdays, left atrial appendage occlusions on Thursdays. So there's a flavor and a method to the madness. Next slide, please. And some other procedures that we do, as you can see here, is that sometimes people can develop holes between the chambers of the heart, and we're able to plug those using plugs, as you can see here as well. And we can also fix overcrowding problems in the heart as well. Next slide. So what I think is exciting is the TMC Cardiovascular Research Program. So we have over 20 and climbing large cardiovascular trials. And the research program started almost 2 years ago. And we started off with a study from Abbott, which was kind of a low yield study, looking at young people who had holes in the heart and closing them to see if there was a post-market analysis and decrease of stroke. But then very quickly, we were able to partner with other hospitals, Henry Ford Hospitals, Scripps Hospital, and also with large randomized controlled trials with industry to have a very large clinical trials program. And these are some of the most selective valve trials in the country. And we're joining Mayo Clinic, Cleveland Clinic, Johns Hopkins, and Harvard in these studies. So, it's something that we should be very proud that we're able to offer we're able to offer just about everything that you can get in a very large city here in Tucson for our population. And initially, I think about 4 years ago when I came here, when we would refer out to Phoenix to be able to send people for some of these larger studies. But things have changed in the last 18 to 24 months, where we now are seeing patients from New Mexico coming from Phoenix, and even Las Vegas now coming to Tucson for these clinical studies, which is something that we're very proud of, that we're able to give people access, not only in these surrounding communities, but we're also able to make sure that people in Tucson don't have to leave Tucson to get world-class care. Next, please. So something that I do want to give you a couple examples of how we've paved the way forward recently. So one of these things is in the left atrial appendage. So as I mentioned, the Watchman procedure, it's a plug that goes in the heart, in this area of the heart called the appendage. And it was FDA approved in 2015, but it only comes in certain sizes. So any appendage that is over 31.5 millimeters, technically we cannot close with the Watchman procedure. And so we can put these plugs in, but they can embolize, they can go somewhere else. And obviously, if we put something in the heart, we want it to stay there. We don't want it to go anywhere else. So I had a patient recently that came to see me, and I had to find another solution for this patient. Next slide. So this is an 82-year-old guy, and you may have read about this recently on the news and also on the TMC website. But this is a gentleman who had an irregular heartbeat, and he was admitted about 5 times for stomach bleeding. And he saw me back around Thanksgiving, hoping that he could get the Watchman procedure done. And I told him, I said, yeah, we'll just do it in a couple of weeks, and we'll put the plug in, and you'll be on your way. So I got a CAT scan done, and what I found on the CAT scan, as you can see here on this black and white diagrams, is that his appendage was way bigger than large Watchman I have. The largest device I have is about 35 millimeters, and it has to be about 10% compressed. There's no way that a Watchman device would have fit in an anatomy that was almost 40 millimeters big. So we had to, and so what I told the patient initially was that, I'm sorry, I can't do this. Let's go back in the blood thinners and we can even try to reduce dose, and then we'll hope for the best. And maybe you'll stop bleeding. We can send you back to a GI doctor, and we can see if potentially, they can try to stop the bleeding through other ways. So that way you can stay on your blood thinner so you wouldn't have a stroke. Next slide, please. And unfortunately, afterwards, unfortunately, this patient got admitted to the hospital 2 times afterwards. And he called me up, very upset that he's like, he said, I don't know that I'm going to necessarily have a chance. And really, I have a chance between bleeding out or having a stroke. And so he really begged me to find something for him. And so, typically in those cases, I would sort of dismiss them and say, well, I don't really have a lot of options. But I knew that there was a new device that was actually out in China and Europe that we were looking at bringing to the United States. And there was a physician in Detroit that had done one in October. So I contacted them, and it was in talks and trying to see what we can do to bring this to a large clinical trial. But obviously this patient could not wait for a large clinical trial. So what I did was I contacted the company, and we used our resources here in the research department to petition to the FDA to get compassionate approval to be able to use this device for this patient. Next slide. So this was actually kind of a large undertaking, and something that at TMC is on the forefront of, because this is a device that's only used in China and Europe. It's only done once before in the U.S. and once in Canada. So this was going to be the second case in the U.S. and the third case in North America. And we had a lot of discussions about what was going to be best for this patient. Is it better to leave them on the blood thinners, or to put a device in that we had limited data for from China, and we didn't have any U.S. trials or any FDA approval to do this. So A, we needed to make sure that we felt that it was going to be safe for the patient, but B, we also had to make sure that the hospital is okay about this, and more importantly, the FDA and Medicare was okay with us moving forward with such a procedure. So what we did was we decided to move forward, and we created a 3D print of his heart, and we were able to find the right size for this patient. We used approximately a 40 millimeter device for this patient. Next slide, please. And what we were able to do is we brought him in, and we actually did the case live. So we had a live stream of the case with the patient's consent. We had doctors from Stanford, Henry Ford Hospital, and University of Pittsburgh watching the case. And as you can see here on the 2 lower black and white pictures is the device going in, and then on the one that looks like a larger device, that is the device in his heart that's fully deployed. And you can see this black ink that's going in. Well, that's X-ray dye. And what I did is I squirted it after I deployed the device. And as you can see here, there's nothing going through the device. So that chamber of his art is completely closed now from any X-ray dye getting in there, which means that no blood can get in there and no clots can form. So the procedure took us about an hour and was a complete success. And the gentleman was having a sandwich 2 hours later, and he went home the next morning, and he was doing great. Now, what are the advantages of doing this? Now, the greatest advantage of this is that we can make a device any size. We can 3D print hearts, and they can custom make devices. And you don't need a whole lot of depth to be able to do this. But the disadvantages so far is that we don't have any US clinical trial data, and we have very limited data from Europe and China. So the biggest thing I ask when I see data is, what is the integrity of data? Has the data been reported as is? What is the oversight of the data? Those are things that I want to know. But just like Watchman, just like TAVR, there always had to be patient 0, patient 1, patient 2 that were able to get to have enough faith in their team to make the right decisions to move us forward. So what this patient has done, by taking a calculated risk that we took and he took through a shared decision, is that now because we have a second case in the United States that has been successful, we are now going to the FDA and asking for to have a large-scale clinical trial, and we will be one of 5 sites in the United States initially to be able to offer this. And what this device does, it allows us to say that we can close just about any appendage that comes to TMC, which is, I think, something that there's no other center that can say that in the United States. So, next slide. So looking at a couple of clinical trials, so obviously Coral, this is a trial that I was talking about, large appendage of Lombre, but we're also looking at Champion AF, which is a low risk trial for Watchman, this is a procedure that is already FDA approved, but what we want to do is change the indications for the trial. And so this is a very large multi-center trial, a U.S. national trial, and we have been a high enroller in this trial, and has been favored very well by the Tucson community. Next slide, please. And then talking about the mitral valve feature directions here, at TMC we have 3 very large clinical trials here. The Encircle M3 trial is actually the one trial that I am most excited about, because as you can see here in the cartoon, this is the first ever fully percutaneous mitral valve, meaning from the groin up to the heart, and we put a brand new heart valve in. And which, as you can see here, there's a docking station, the slinky, the white slinky that goes in there. And then in that slinky, we're able to put a valve inside of it. And so again, we're learning about which anatomies this will work in and which one it won't work in. But we also have now a different device. We only have the MitraClip that was available. So we have the CLASP trial, which is looking at a Me Too device, is what it's called, when you have a device that kind of does a very similar function, but has maybe some mild modification. The Pascal device is essentially a clip, but has a few other features to it that in certain anatomies may be more favorable to the clip. So we're doing a randomized trial looking at comparing these 2 devices to each other. And the last trial is the Repair MR trial, which is, again, another indication changing trial. Right now, MitraClip is only reserved for patients who are high and prohibitive risk, meaning they cannot go under surgery. But now we're looking at patients who could be surgical candidates and randomizing in surgery. Again, a very large clinical trial that Cleveland Clinic, Mayo, Harvard, Johns Hopkins, Cedars-Sinai are all involved in, and we're proud to be involved in that. We haven't randomized so far 1 patient in that trial. Next slide. Then for aortic valve disease, we have multiple trials comparing different valves with each other in different body habitus. Next slide, please. So one quick thing I will end with here is that we talked about, we have a lot of trials going on, but as far as innovations, sometimes the innovations that we have really come from the lab, and they really come from animal models. So there's in some patients, their groin arteries are not big enough to suit a TAVR, because either they're calcified, very bendy, and may not be able to get a very large valve through that. And as you can see here, this is an artery that was suboptimal for putting in a TAVR valve, and a patient who was morbidly obese. Their body mass index was over 45. And we had to be able to put a valve in her safely without creating a major issue. So there was So there's a concept of being able to use a vein and cross over from the vein to the artery to put in a brand new heart valve, and then close up the aorta. Those of you who may not be familiar with this, but it's called a retroperitoneal stick, and it's a stick that you essentially go from the inferior vena cava into the aorta. And this was tested in actually 10 pigs back in 2013 at the NIH, and they found that that the pigs didn't die. And then so they studied exactly why this pathology. Why this pathophysiology was true, because you would think that if you stuck a needle in that particular spot, traditionally the conventional thought was that the pigs would die, and as we see with people who have very large aneurysms, who have bursted aneurysms, they don't do very well. So why did these pigs survive? And what they found was that there was a certain pressure in the back that actually keeps the blood flowing actually from a high pressure circuit to a lower pressure circuit. So then in 2013, there was a patient at Henry Ford Hospital being cared for by a guy named Adam Greenbaum. And what he found was that he was not able to put a valve in the conventional way. So he actually contacted this gentleman he's a cardiologist that had this pig lab at the NIH in Washington, D.C. And he says, hey, I heard that you have a new way to do this. Maybe I can bring this from the animal model to the human model. So after he went back up to DC, did it in another 10 pigs, figured out how to actually bring the technique to human beings, and he did his first one in 2013 and found that the people did quite well. And so to date, there's been approximately 500 of these, roughly 500 worldwide procedures done in this. We were the first to do this in 2019, and we've done 2 of these procedures today. It's not very common, but both patients have done extremely well. Next slide, please. Next slide. Next slide. One more click. There you go. So as you can see here, as I was mentioning, there's 2 places when we're going through the arteries in people that we get particularly concerned about. And they're oftentimes where the junction where the arteries meet the aorta, and the other part is exactly where we would stick the needle into the artery. So those are 2 particular areas. So this is why this new technique was developed. And again, it's reserved in a very small number of patients. So it's kind of a niche technique. Next, please. So what I want to show here is an angiogram, and I thought it would be kind of cool for everybody to see this. And what it involves is the first diagram that's playing over there is the aorta. So what we're doing is doing a contrast injection of the aorta to find a site for us to do this. And the next middle diagram is us basically taking a catheter into the vein and essentially putting it into and having a snare parked in the artery. So what you can see here in the third picture here is what we're trying to do is get this wire to go through the back using a bullseye target. And we're electrifying this wire and make sure that we don't poke the wire too far. So next slide, please. So in this particular case, we were able to electrify that wire, poke it right through the perfect part of the aorta. We're able to snake the wire into the catheter, which is the angiogram number 2. And in the third one, you can see here is now we're advancing the wire to create a rail. So now we're able to get to the artery. We've created a rail. And then on the fourth one, what you can see here is we're able to advance some of our stiffer devices in there. And the last one here, as you can see here, this big trocar essentially that we would typically go through an artery with, but the arteries were too small. We're now able to go directly into the aorta with this sheath and deliver the valve as we're supposed to. Next slide, please. And so then we were able to put this valve in. As you can see, this is a balloon and a stent, and a valve is on the stent. And what you're seeing here is the TAVR procedure. So we're able to go from a vein to an artery, get the valve positioned to where we want to go. And once we were happy with that, then we blew up this balloon that already had a stent valve on it, blow this up to the size that we needed for this particular patient, and then and give her a brand new heart valve. Next. And then, of course, we had to pull our equipment out and we had to close the aorta. So we found that if we use a plug that we would typically use in the heart to close holes that are in the heart, it actually does quite well to close heart holes in the arteries. So as you can see here, this is deployment of the plug in the aorta. And as you can see on the very last angiogram, which is the fourth black and white picture, you can see how there's no more hole in the aorta, and we've completely sealed that up. And the patient went home in 2 days later. Next slide, please. And we're almost at the end here, but for oftentimes what we call the forgotten valve, the tricuspid valve, we are just now starting enrollment in the Trilumina trial, which is looking at a clip in the tricuspid position. And we are looking at a very large array of other devices, one of which is a potential early feasibility study that only 2 or 3 sites in the whole country will be a part of, which we are hoping to be able to announce sometime in late this fall. Next slide. So this concludes my presentation. What I really want to say is that it takes a village to do what we do and to do it really well, and it really takes a village to pave the path forward for others. In this picture, this is the team that I did my first transcable with, but there are so many other people that are not pictured in this that are involved on all different fronts for what we do. So I think that with that, I'll open it up to questions, but I really appreciate you giving me a chance to tell you something that's near and dear to my heart. Thank you.
So thank you very much. That was really, really informative and very well presented so that we could understand it. Are there any questions from the group? Because I have several questions, but I want to give others an opportunity to ask. But if no one has anything, I'll be happy to ask. So if I see any hands raised or anything, okay, I'll start then. So you touched upon this a little bit, Doctor. And so I just want you to tell us, how do you determine what is the best technique that will work for an individual patient? What's the criteria you use? You kind of told us a little bit as you were going through the different phases, but how do you determine that?
Yeah, that's a great question. So I think that the biggest issue is that the first thing I have to do is look at who the patient in front of me. Look at the patients in front of me. Who are they? Are they somebody who has a lot of medical issues or somebody who has no medical issues? Okay. And then third, what is their social support? What kind of support do they have at home? And I think those are really important considerations just before I look at anything objectively. And then once I look at things objectively, I'm looking at myself and saying, okay, am I taking somebody who is risky, a high-risk patient, and doing a low-risk procedure on them? If I'm doing a low-risk procedure on a high-risk patient, then I think we should go with the low-risk procedure. But if I'm taking a low-risk procedure and doing a high-risk procedure on a low-risk procedure, then we got to be rethinking about what we're doing. And I think that's why I think that I like to brand ourselves not as a structural heart center, but as a valve center, meaning that we have to look at all these therapies. Surgery is not going away. Dr. Katari, Dr. Bose, Dr. Butler, Dr. Sethi, they're gonna continue to do to work alongside us. And our goal is to figure out for this individual patient that's right in front of me, based on all the first few factors I had, then the clinical factors, what are they going to do best with in the long run? For some of these patients I have to think 15 to 20 years out, the therapy that I can offer versus the therapy that Dr. Sethi can offer, what is that patient going to ultimately do better with? Now, if somebody who's 60 years old and has another 20 or 25 years to live at least, we have to think about putting in a device that is going to give them that longevity. And it may not be the device that I can offer because I may not have that long-term data. So we have to be able to say to ourselves that, am I doing this? Am I thinking long-term? Now, if I'm dealing with somebody who's 85, the long-term, it looks a little bit different, and it depends who that 85-year-old is. Is an 85-year-old who's expected to live another 2 years, or somebody who has no issues at all, who could easily live another 4 or 5 years and make it to 90. So, but in those cases, those particular patients may not be the greatest surgical patients. So really, I think a lot of it's just understanding who's in front of you, and the most important thing is to talk to our patients and their families.
Mike, you have a question? You're muted.
And Dr. Gheewala, I was curious how it is that the implanted valve actually stays after you pull the catheter out.
That's a great question. Friction. So those valves, the valves, we can, for the aortic valve, we can only put it into a narrowed aortic valve. We can't put it in a leaky aortic valve yet, not yet at least. but we're working on that. But a narrowed aortic valve is narrowed because of calcium, and it's really like a rock. And so, and the thing is that, and there's so much tension there that when we're putting the brand new heart valve in, that tension is still there, and that friction actually holds the valve in place.
I guess in my case, it's the previous valve that was holding in place, and the next one will be the 2 previous valves that hold it in place.
Oh, is that right? Okay.
They're currently scheduling me for a few weeks for my second TAVR, a TAVR within the TAVR, within the open heart valve. So
This will be your second TAVR within a TAVR?
my second TAVR, first TAVR within a TAVR, the third valve. The first one was open heart.
Oh, I see. Okay. Wow. Well, best wishes to you. Yeah.
I'm hoping I'll be there in the halls in a few weeks.
Yeah. Well, reach out to us and let us know how we can make sure your care is excellent. So.
I think we've already got the best people working on it, so hope for the best.
Thank you.
A follow-up to my question is, what are the ages of your patients, and do you do pediatric patients as well? Because you do have a children's hospital there.
I do.
Children's center.
Yeah, so I don't specialize in pediatrics. I actually leave that to people who are adult congenital cardiologists. Dr. Sakeller, who I know very well at the university, he has a lot of patients. So the nice thing, what I like to do is I cross collaborate a lot with him. You know, patients who have pulmonic issues, who may be in their early 20s, 30s, who were operated on as a child. I like to make sure that, you know, the most important thing is making sure that the person who's doing it has done a lot of these, and that's where we do. So we don't deal with any children. And what was your second question?
Just the ages of your patients.
In general, so I see anybody who's 18 and above, you know, but in general, the majority of our patients that we take care of for these issues are in their late, probably the mid to late 70s for the most part, on average. But we've taken care of a lot of people in their late 90s too.
Other people have questions? Donald?
Dr. Gheewala, when you did the Lamprey procedure then because it was a special one-off, so to speak, with the government, did you have to send them a huge amount of details on how it happened and the outcome, and when will that get signed off by the FDA?
That's a great question. So yes, they request a lot of paperwork. So the big thing was that I had to make the clinical justification to them. I had to write a letter to the company who makes the device because they have to be willing to give me the device. Third, I had to have a physician outside of TMC to be able to review this case and to make an independent assessment. And then we had to have the IRB approved. So we had a lot of things, a lot of moving parts here. My job is to report back to the FDA, which needs to be the next 2 weeks or so, to inform them of how the patient's doing. And so that's something that they want to follow up within 4 to 6 weeks. So that's something that's expected. Now, the FDA will not, this will be quite some time before the FDA fully approves this, because we have to have a randomized trial looking at this. So we're starting with large appendages. And so currently that is in the FDA has approved the trial protocol. But now we have to operationalize the trial. And that's something that my colleagues in Detroit are working on.
And Doctor, when you were starting that specific procedure that morning, 15 minutes before you started, how do you get your team they're dealing with something for the first time. How do you get them totally focused and chilled out so they just go after the end goal? Is that just keeping them totally calm?
Yeah, so this is, so the most important thing is, they say keep calm and carry on, I think that's something that is a very important thing. But I think that, I sort of consider myself the team leader here, and so without them, I can't do any of this. And so what I did is we started the procedure a little bit late. I made sure that they were debriefed on this. They had their hands on our model device, and they knew exactly what we were doing and why we were doing it. Because the most important thing is for them to know why we're doing it, and that we've crossed our T's, dotted our I's, because they're part of something, and they're part of something that, there could be a outcome that we something could have happened, you know? So we wanted to make sure that they knew what to anticipate, what equipment we would need for bailout, and at what point we would signal that we would need those things. So I think that's something that took a lot of time. So we did, and then what I think is really important is to do a debrief to make sure that we talk about it afterwards, so everybody learns something.
Thank you.
I have a two-part question. Is the research done at TMC or is it done at Pima Heart? And can you tell us what is the makeup of your team? Do you must have probably, I don't know, what is the makeup of your team? Do you have case managers, social workers, ICU nurses? What's the makeup of the team and where's the research being done?
Yes, it's being done at TMC.
Okay.
It's not, they're mostly Pima Heart patients, but it's being done at TMC. We have our lead research coordinator. We have two other research coordinators who work together. We have a cardiovascular research fellow and who's a physician. And we also have, they work in parlay with our structural heart coordinators. We have 4 nurse navigators who are nurses, and they have clinical background. So they work hand in hand with our clinical research coordinators to make sure that when we identify a patient as meeting criteria for this, that they make sure that, because they have the clinical background, to make sure that they talk to each other.
And what's the follow-up for these patients?
It's varied. It depends on the clinical study. Generally speaking, the protocol before the study, when the FDA approves it, they will predetermine what that follow-up will be. Oftentimes it's 1 week, 1 month, 4 months, 6 months, and 1 year. That's generally what they are. But every one of them is very specific. And some of those can be follow-ups over the phone, and some of those can be through the mail with getting questionnaires done. Or in some of them require in-person visits. So it just depends on the nature of the study.
Does anybody else have questions for the doctor? Okay, what's the final message you want to leave with us?
It takes a lot of people to do what we do and do it well. And, I think that there's a lot of gratitude that I have toward, for TMC and the foundation for all the support that we've had over the years, and we look forward to continuing to have.
And my last question, are there needs that you have that are unmet, and what would be your priorities?
One of my biggest needs right now is a GE PACS system. Which is a way for us to have a database. So that way there's 2 things I want to do. So one is our echoes that we have, for example. We do special screening echoes, and we use 3D technology to do this. Now the machines that we have capture the data, but then the machine has to transfer the data somewhere. We don't have that somewhere to put it right now, the raw data. And so what we desperately need, and I've been in talks and conversations with Roxy and John Warden and many others, is that we desperately need a GE General Electric PACS system, which is a database, so that way, A, we can archive these studies, and B, we can pull these up and manipulate these wonderful 3D images that we have, so we can understand patients' images better. So I think that's something that that is our top priority right now, and something that is, if anything, is slowing. The lack of that actually slows down our clinical enrollment for clinical trials, because sometimes we have to repeat the study because the original data that's on the machine gets wiped every 2 to 6 weeks. And so if we don't have a place to store that data, we are in trouble. So we've tried flash drive, we've tried burning CDs, and there's no better way than just to put it. So that's priority number 1. And and the other priority that is less pressing, but I think is very important, is for us to be able to have technology software to be able to manipulate our own CT scans, called 3Mensio. And what that does, it allows us to take a CT scan, but then to create these virtual renderings. Right now, we rely on industry to be able to create those renderings, but I think for us to be able to, for the number of procedures that we do and the depth of which we do this, I think that to be able to manipulate them myself would be very nice to be able to do that. So.
Doctor, I've got a question there. Sorry, Adeline, based on what you were saying there about wish list, if you had your mega wish list and your highest item, what would that be?
The GE packs.
Somebody come in and just say it, and to write you a check. What would you suggest for that?
The GE pack system.
Okay.
Yeah, that is the highest priority I have right now. Yes.
Thank you.
Well, are there any other questions? We're at 6:02. It's been a fascinating discussion. Thank you so much, Doctor. We really appreciate your time, your talent, and your willingness to share all this information with us. Any other last-minute questions from anybody? All right. Well, then I thank you very much, and we'll look forward to having more We Are Champion lectures similar to this, and we'll keep our audience posted. Thank you very much, and have a great evening.
All right, take care. Thanks for your time. Thank you.
Thanks, Neil. Great job.
Thank you.
Thank you. Thanks, Jim.
Okay.
Thanks.
Bye.